frontline providers play with diagnostic and antibiotic stewardship. Next slide. So this is a CDC infographic, and I show it just because it kind of targets on the fact that we really do have overprescribing going on. And that second round circle from the left at the top shows that in the acute care settings, 77% of patients are diagnosed with urinary tract infections are treated inappropriately with antibiotics, and specifically so they're treated in the absence of clear indications for prescribing an antibiotic. So lots of opportunity with that group. Next slide. And so this is just another infographic focusing on the long-term care setting. And what it shows is that roughly 4.1 million residents live in a long-term care setting. Of those 4.1 residents, up to 70% will receive an antibiotic at some point in time over the course of the year. And then of those 70% that receive an antibiotic, up to 75% of those will receive an antibiotic inappropriately. So again, prescribed in the absence of clear clinical indications. Next slide. So this slide just touches on each of the core elements, and the core elements are essentially the same whether you're in an acute care setting or a long-term care setting. With this talk, we'll focus on the last four core elements. So action, tracking, reporting, and education with respect to how your frontline staff or your bedside nurse plays a role in each of those elements. Next slide. So again, going back to the previous slide, action, tracking, reporting, and education. And historically, the traditional teams, these would fall to primarily your leaders of your antibiotic stewardship team. So your physician, ID physician, or a physician if you don't have an ID physician, or the pharmacist to address each of those. With respect to nursing, what the current literature shows is that nursing really does play a role with respect to action. They can implement a timeout. We want nursing staff to understand those lab reports that come. So we work with them to explain what a sensitivity report is and what all the information on that sensitivity report is. So they impact that. Tracking, again, antibiotic timeout. But the other big thing from a nursing perspective is that conversion from IV to PO. Oftentimes that was seen as a physician or pharmacist role. But if you think about your bedside nurses, they're the ones that are advancing diets based on how that patient is doing. And if they understand their role in conversion from IV to PO, it helps them better drive this piece. The goal is to get IV access out. So whether it's a central line or a peripheral line, if we can get them to full food, we can get them on oral medications, we can get that line out and just reduce risk. With respect to reporting, oftentimes that reporting went back to Pharmacy and Therapeutics Committee or to your Medical Executive Board or even to your Infection Control Committee. But with respect to reporting from the bedside caregiver or your nurse, they can take information back specific to antibiotic stewardship and diagnostic stewardship and share that information at their staff meetings or within their teams to help the bigger group on the unit understand kind of what's going on, what antibiotic stewardship is, and how the bedside or the frontline staff play a role in that. And then with respect to education, generally it's been around physicians and pharmacists and different clinical pieces to that. But what we'll talk about as this presentation goes on is the role that nursing plays in education. Nurses can educate physicians in addition to physicians educating physicians, but nurses also are key in educating their colleagues. So other staff on the unit, they work with their patients at discharge, helping them understand their medications, and then also with the families of those patients. So just moving forward, those really can be 4 elements of the 7 that nursing can impact. Next slide. So here, just think about what your team's going to look like. It might not be the traditional team. what works in one hospital down the street is going to be different from what works in a community or a rural facility. So just think about your team, think outside the box. Next slide. So with this one, the critical role of the staff nurse in the antibiotic stewardship, and I realize that this is a little bit small and I apologize, but this is really a good study published in IDSA, and it talks about traditional stewardship models relying on pharmacists and infectious disease physicians, or both, as drivers with providing feedback to clinicians. And what I like to do is share that nursing also plays a role in this. In a lot of the initial studies, they talk about the traditional antibiotic stewardship teams as being your pharmacist and your physician and your infection prevention and so on and so forth. But they've never really identified nursing as kind of a key team player. And what this study does, and especially in that smaller slide to the right, is it kind of bullet points each of the elements along antibiotic stewardship that nursing plays a role, places where nursing is already doing the work. And so it really makes us think about how we can pull nursing into it and where they can really help boost up or bolster our infection prevention work and antibiotic stewardship. Next slide, please. So this plays off a little bit on what I was talking about before. And I think if we think about nurses and how they really kind of become that central communicator, and that's what this study and the prior study talk about, is nursing as a central communicator. And in this diagram, CDC and ANA put together this white paper a few years ago to really show and highlight the role of the bedside nurse. And that bedside nurse kind of controls everything for that patient. So they know what's being ordered. They know what labs are being done. They know what medications the patients are on. They know just all the intricacies. And so if we think about how they can help with the antibiotic stewardship work and diagnostic stewardship, it just helps us have a more robust, effective team. Next slide. So this is just another part of that CDC and ANA paper. And what they did here as part of their work is they looked at the role that nursing is already doing. And so in that first column, they talk about stewardship activity work, or the task of antibiotic stewardship teams. And in that second column, they talk about the CDC core stewardship elements. And that third column, they talk about responsibility of current antibiotic stewardship roles in the model of CDC's core elements. And in that last column, they address each of the elements that nursing has already done, but is unrecognized as a role of the nurse. This is actually a 3-page document, and it's pretty in-depth or in detail about the role that nursing can play. So I'd just like to share some of that new literature that's out there and how we can use it moving forward to build our teams. Next slide. So moving into diagnostic stewardship and trying to pull those two together and paint a bigger picture. If we think about how nursing is the central communicator from that prior slide, diagnostic stewardship falls directly under the role of that nursing or frontline provider, because physicians can order the test, but nurses need to know if it's the right test. They need to make sure that it's being done on the right patient. They need to make sure that it's being done at the right time, whether it's an antibiotic therapeutic level or a urine test of some sort, urine cultures. There's all kinds of things that fall into place, and that diagnostic stewardship falls directly under the role of the bedside provider or your nurse. Next slide. So here we talk about diagnostic stewardship and really what diagnostic stewardship is and what it's not and why it's important. So in thinking about diagnostic stewardship, it's critical in improving patient care and combating antibiotic resistance. And the antibiotic resistance piece is making sure that we're doing the right test for the right patient at the right time, and that we're doing it well, so that if nurses are pulling cultures, they're doing those cultures in such a way that we're going to get a report that is accurate and valid versus potentially being contaminated. So I think we talk about Testing wisely, and we'll talk about that on the next slide, but choosing wisely, making sure that we're doing the right thing at the right time for the right reason and not just doing things for the sake of going through the motions. So let's talk about choosing wisely real quick. Next slide. I'm not sure, hopefully a bunch of you guys are aware of the Choosing Wisely campaign, but it's an initiative of the American Board of Internal Medicine focused on advancing a national dialogue around avoiding unnecessary medical tests and treatments. And this one on the slide, so let me backtrack just a little bit. Choosing Wisely has about 50 different societies that work with it. So, and the American Nurses Association is one of them. The American Society for Microbiology is one of them. The Infectious Disease Society of America is one of them. What they've done is pull 5 different things that can be done or that shouldn't be done in different elements of patient care. Testing is one of them. And what this Society of American Society of Microbiology has done is talk about not testing stools more than once a week in patients for C. diff, and why it's important not to do that. They also address not ordering urine cultures unless patients have symptoms consistent with a urinary tract infection. And we've already talked about all of the patients that have that are diagnosed with UTIs and treated with antibiotics in the absence of clinical indication. So the nice thing is that these documents are usually one page. I say there's front and back. The back side of these documents will have references and resources that were used to put this information together. So it's really good information that you can share with nursing, you can share with physicians, you can share with anybody to understand kind of what they should and shouldn't be doing with respect to some of the antibiotic stewardship and antimicrobial stewardship work that we do. IDSA has another good one, and they talk about not treating asymptomatic bacteriuria with antibiotics. And then they again talk about avoid testing for Clostridium difficile infection in the absence of diarrhea. So just a resource I wanted to make sure that you guys were aware of that's out there that is easy and free to access. Next slide. So getting back to diagnostic stewardship and a takeoff of the choosing wisely, I like to say testing wisely. And again, what does diagnostic stewardship mean? Good laboratory diagnostic stewardship is making sure that we order the right test for the right patient at the right time. I'd like to add in there and in the right way, making sure that if we're doing blood cultures, we're getting those blood cultures in such a way that we're not going to end up with potential contaminated cultures. Same with urine. Diagnostic stewardship is related to antibiotic stewardship in that an incorrect diagnosis can lead to an inappropriate antibiotic and potentially failure to treat with an antibiotic when one might be needed. Next slide. So these are 3 of those low-hanging fruit that I mentioned early on that a lot of the literature supports in terms of areas to start with diagnostic stewardship that should be, I don't want to say easy to impact, but can be done in any of the settings that we're talking about, whether it's acute care, long-term care, or even the clinics. And again, just making sure that we're not pulling cultures if there are no clinical indications, and making sure that we don't have standing orders for a UA to reflex to a urine culture without clear indications. And later in the presentation, we talk about part of that team. Part of your antibiotic stewardship team might also include having somebody from clinical lab or from the microbiology lab involved, because they're going to be able to help with making sure that we're not reflexing urinalysis to urine cultures when it's not appropriate. Testing for C. diff, making sure that staff understand when to test, that you don't want to send a urine specimen, or not a urine specimen, a stool specimen if the patient really is not having diarrhea. Understanding what tests are being done at your facility and then what those results mean. And then making sure that they understand that there's no evidence to perform a test of cure for C. diff. If a person if the diarrhea has resolved, there's no reason to do any further testing. And then the other piece is with blood cultures and making sure that blood cultures are being drawn appropriately. And that, again, falls back to the frontline staff and to nursing to work with lab to make sure that they have a process in place so that those blood cultures are being done appropriately and in the best way possible so that you can eliminate or reduce potential blood culture contamination. Next slide. So this is a busy slide, but I think for me, it's one of my favorite slides to use for education because it hits all of those things that we've talked about so far in terms of what to do, why to do it, and why it's important. And so let me try and make my slide a little bit bigger. When we talk about ordering, making sure that we're ordering appropriately. So test only if clinical presentation is consistent with the infectious etiology or with whatever the test is that you're ordering. So if a patient has cloudy or smelly urine, in the absence of true clinical indications, the smelly urine or the cloudy urine isn't a driver for obtaining a urine culture. Paying attention to sample collection and transport. And I think sometimes we forget to educate those frontline staff on why those are important. Sample collection we've talked about, making sure that we are obtaining a good sample, but then also educating on the need to get that culture down to the lab in a timely manner and not letting it sit up on the unit for 1 or 2 hours until somebody, number one, either has time to take that specimen down, or sometimes, so my background was neonatal ICU, and it was a big 50-bed unit. And so what we would do is we had a central place that we would put our labs, and depending when our baby's cares were due, we might start drawing our morning labs at 3 in the morning. And then maybe staff wouldn't finish until 6:30 or 7. And so everybody would put their labs in a central place. And then at the end, somebody would take all of the labs down. What I learned once I got into infection prevention is that's not a good process, because that meant some of those labs were sitting there. Some of those cultures might have sat for a couple of hours. Another opportunity for education with respect to sample collection and transport is for those of us that are nurses, how many times did we get blood cultures just because we were drawing other labs? And then you let those cultures sit until the doc decides they want to order them. And so those cultures might sit for, again, 2 or 3 hours, and then that baby pops the temp or something. And so at that point, the doc might say, oh, let's send those cultures. Well, if those cultures have been sitting at that bedside for an extended period of time, you may as well just get them over again. So again, going back to education, helping the bedside staff understand the significance there. If available, using adjunctive laboratory tests to distinguish colonization from infection. And with this tool, they speak specifically about C. diff testing and helping staff understand the difference between PCR versus another test that's being done. So again, going back and educating staff on what you're doing at your facility, understanding what tests are performed in the lab and the meaning behind each of those tests, and then reporting results in a format that guides appropriate practice. And so that might come into play with those lab reports where some of the results are suppressed. And if a physician is looking for something specific, they would have to call the lab to get that, versus just having everything on the lab report and the physician maybe keying into a piece that's not important, but to him, he thinks it is. So just, this is a good tool. It was a good article to use for educating on diagnostic stewardship and how it plays into the big picture of everything. Next slide. So this, I'm going to go back to just allies to the antibiotic stewardship team. And again, nursing that's already there. We're already doing the work. pulling together a multidisciplinary approach that can help bolster and support the work of the antibiotic stewardship team, engaging those providers and ensuring that they adhere to the stewardship policies. In small hospitals, having that multidisciplinary representation is ideal, but not always feasible. And I'm going to go back to something that I said earlier, in that in a large academic medical center, it's easy to have that ideal team where all areas are represented, and you have an ID physician and you have an ID pharmacy, and you have an infection preventionist. The smaller rural critical access facilities aren't going to be so fortunate to have each of those. And so realizing that you need to pull together a team that can fill those roles in a successful way. And so thinking outside of the box, and that's kind of what this article talks about. They give some really good examples as to who might be included on your team and why they can fill a role that the traditional team would do. Next slide, please. So this is another tool that I like to use with educating, and I'm going to backtrack just a little bit. Any of the stuff that I've shared in terms of the literature out there, in my experience and in my years of working with antibiotic stewardship and infection prevention, I use these with physicians. I've used them with lab personnel. I use them with bedside staff, and I use them when working with new novice IPs as we're trying to help mentor them. This is another really good one. It's an easy tool to use. It's not very long, but they actually go through scenarios and get you thinking about, in this situation, if a physician wants to do X, why is it not okay? And it gives you resources to use to help correct maybe not the best practice. So why sending urine cultures only when necessary? And they talk about what necessary would be, what those clinical indications are. Urine triggers with respect to that refluxing UA to a urine culture, why you don't want to have that as just a standing order, why you don't want to have standing orders in the ED for everyone that comes into the ED to have a urine culture, and the implications behind that. So just a good tool that is easy to use regardless of who you're working with. Next slide. This is part of that prior tool, and I like this because it's one page and it is pretty cut and dry. When to discourage urine culture use and when it's appropriate for urine culture use. And with this article, they focus mostly on those with indwelling urinary catheters. So it's somewhat focused in terms of what they're working with and what their guidance is around, but just another good tool, one page, simple and easy. And if nothing else, sometimes for me, I found that this drives discussion and you talk more in depth. Pan culturing has kind of gone away. And there may be some facilities that do still pan culture. And so why is pan culturing not necessarily a good idea? Some of these articles will talk about that and how you can move away from pan cultures. Next slide. So this I share just as a success that I had with diagnostic stewardship. In our facility, we had a significantly high blood culture contamination rate. And when we were fortunate enough, again, working in a large academic medical center, we had support for developing infection prevention champions. And those champions then consisted of everybody throughout the facility. So we had dietary, we had lab, we had housekeeping, we had anybody that was going to have any impact with patient care involved with our champion group. And so the lab brought to us the blood culture contamination rates and wanted to know if our champions would work on it. And so we validated the data, and what we discovered is that the majority of our contaminated blood cultures were coming out of the ED. And so when we went down to the ED and we did some observations and we talked with staff, we found out who were drawing the cultures in the ED, and then focused our education on those groups. So nursing and phlebotomy. We put together a process, we put together tools that they could use to help them understand how to draw blood cultures. The lab worked with them to help put in place a process when you're drawing blood, what goes into which tubes and in which order, to make sure that we got the best blood culture specimens possible. So we implemented all of the interventions. We did all of the training and education. Our ED blood culture, our hospital blood culture contamination rate initially was above 6%. Our ED was above 7%. After our training and education, our first quarter blood culture contamination rates dropped from over 7% to 2.91%. And then our second quarter, I'm going to backtrack. That same quarter, our hospital blood culture contamination rates dropped from just above 6% to 1.97%. And so that's then where that nursing staff can take back the education and share the successes at the unit level. Because we, as IP and the antibiotic stewardship team, took the information to the executives. We took it to pharmacy and therapeutics. We took it to the infection control committee. But if you don't take it back and share those successes with those who are doing the work, you don't necessarily you miss an opportunity to really help them see the big picture and how they impact patient safety. And how we explained it to them is you end up doing far fewer blood cultures because you're not repeating blood cultures. So you're reducing pokes to that patient, significantly reducing the amount of false positives when you have docs then that don't know if they should treat or not. So you're treating patients with antibiotics. So just a huge opportunity to share positive work that we did. And staff are really proud of the work that they did, and it helped us drive that bigger support across the board for future work moving forward. Next slide, please. I'm going to go back to another article. So going back to nurse-driven antibiotic stewardship and how they can play a role. And this is an article, I think, that came out in the American Journal of Infection Control in 2020. And they went back to specifically look at how to move the work forward with antibiotic stewardship and the bedside nurse. The study identified that clarifying antibiotic duration was a prime area for future nursing antibiotic stewardship efforts. And we've talked about that throughout this presentation. Nurses identified antibiotic stop discrepancies, which is another big one. Whether it's a patient in the hospital or a patient that you're educating on discharge, you want to have a good stop date so that they know when their antibiotics are done. I can't tell you how many times in the hospital when I was still working in the hospital, and you call the unit and you talk to the nurse who's caring for the patient who's got positive blood cultures and they're on antibiotics, and the nurse didn't know why they were on the antibiotic. They didn't know what the culture showed, and they didn't know how long the patient was going to be on the antibiotic. And so I think those were drivers for us as infection prevention, and then for the antibiotic stewardship team to really start educating at the unit level with those who are doing the work, which goes back to the nurses. I'm going to have you go to the next slide because it'll be easier to talk about this tool. So this was the tool that Dr. Monsees and her team put together, and it goes into more detail about what antibiotic stewardship is, and it's kind of a checkoff list that the bedside nurses can do to address all those pieces of antibiotic stewardship. So what is an antimicrobial? We hope that those at the bedside understand, but never assume anything. So it can help them answer some of those questions. What is the planned duration? So this helps with respect to when rounds are being done, and you've got pharmacy and the physicians and the nurse taking care of that patient doing rounds. Nurses can have this when they do rounds. And if there's a patient on antibiotics and there's no duration documented or there's no discussion of duration, she can use this as a prompt to start asking those questions. What are just indications for antimicrobials? So if I, as the nurse, don't see any clear indication as to why this person is on an antibiotic, and I'm not seeing anything in the progress notes, I feel more confident in asking, or hopefully we can educate the bedside caregiver to ask those questions about indications. Why did we start this antibiotic, and how long is it going to go on, and so on and so forth. So just another really, really good tool. The right side of this screen talks about, again, the antimicrobials, duration, indication, but they also prompt that oral. So when can we go from IV to oral? What's the target for that? Is it just when somebody is on full feeds, or are there other things that we want to look about? So just a really good tool. It got really positive feedback from the staff that used it. And so I think that is how I wanted to end, and just make sure that you guys are aware that some of that information is out there. Next slide. I'm going to end here and just reinforce that redefining the antibiotic stewardship team is key to building an effective multidisciplinary team. And just again, reiterating that think outside the box. The traditional teams of yesterday are not necessarily the teams that will be effective today. And depending on your setting, your size, your resources, what we're doing at a large academic medical center may not be what you do at a rural community hospital. And then again, thinking outside the box, adding team members that are respected influencers and that can drive culture change at the unit level. And I think I'll end it there, unless you guys have questions.
Terry, thank you very much. That was a wealth of information there and a very nice overview.
Thank you.
Any questions out there? Amy's asking, how do we access the recording? Jenna, you want to handle the recording piece?
Recording will be posted on the Mountain Pacific Quality Health website. Probably usually takes a week or two to get it up there, but if you would like the recording before that, shoot me an email and I'm happy to send a link.
Good, thank you. Terry, I have a question for you.
Okay.
So in your experience, what's been the most difficult issue in starting or getting an antimicrobial stewardship program off the ground?
With respect to, well, it depends on the settings. I think for me, one of the biggest things is having the right people at the table. We talk about antibiotic stewardship and nurses' role, and the key that can play. So for me, helping nurses understand how they fit into the bigger picture. And initially that takes a time commitment, being up on the unit and walking them through why it's important. And what I did when I was still at the academic medical center is on Wednesdays on one of their units, every Wednesday morning for 2 hours, they did in-depth rounds. And so I physically went up and walked them through rounds. So as questions would come up, or if something wasn't addressed, I would prompt that and physically show them how to do it, till they got to the point. And usually it was the charge nurse that was involved in those rounds, the charge nurse and the nurse caring for the patient. So just role modeling to them. And again, that's where this audios tool comes into play, helping them see that these really are key pieces that they can take ownership of. And so if the ID physician or the ID pharmacist isn't bringing up one of these pieces, I, as the nurse, can bring it up. That's my role in caring for that patient and providing safe patient care. I worked in Alaska for a while, and the challenge I had there was getting the they had an ID physician who was also an ED doc as the team lead for their antibiotic stewardship. And we had big issues in the ED with urine cultures being ordered on everybody. And I was able to actually show a couple of patients who had urine cultures ordered inappropriately, no indication. It was just a pan culture, everything. And they treated them with an antibiotic, and almost textbook, they developed C. diff, and then this person ended up with 6 months of fighting through C. diff and reoccurrences. And so that was more time intensive because it meant going back consistently and sharing these lapses and opportunities and trying to have them, asking them explain to me the indication. And that goes back to the audios tool again. What's the indication? Why did we start antibiotics on this person who didn't have any indications? And so initially it's time intensive and a lot of manpower. But in my experience, when you put that in up front, you get your success comes down the road. And in the end, you reduce your manpower because they already understand. And then they move it forward. They become those teachers on the units and those teachers in the ED that can help understand why we do what we do.
Great. Thank you. Any other questions out there?
So may I make a couple of comments?
Absolutely. Thank you.
So thank you, Terry, for kind of presenting one of my pet project. And I'm going to show you a little shortly. Actually, I'm writing I'm lead author on this paper with several of the SHADE members regarding diagnostic stewardship and antibiotic stewardship. But to kind of follow up your comment about the physicians and building these well, I'm trying to work with these physicians and trying to nudge them. And essentially, that's what we're doing. Is that it's very important, and I think that's the thing. Is it's the relationship building. And all of this, regardless of how you're going to consider whether it's in the antibiotic stewardship or diagnostic stewardship, if you don't have that relationship well founded, none of it's going to work very well. So, if there's one major take-home message is that as if you're building your program, at the beginning, put a lot of effort into building that relationship, build that trust, because anything you're going to do, and if you don't have that relationship, and anything you do is us telling them what to do, and that never really usually end well.
Right. That's exactly key. I thank you, Dr. Koo. You said it better than I did, but that's exactly what you're doing when you're out on the unit and you're helping them put the pieces together, and you're helping them have that aha moment as to why we want them to do what they need to do. And we're providing the literature behind why it's important, because the bedside nurses don't have time to do that research. And oftentimes, if they don't understand, they're not going to ask questions and drive the discussion because they don't feel that they're the expert. As we build those relationships, we build their knowledge, because that's where they then develop their competence, when they understand, and then they learn to ask those questions in a way that's not accusatory or put somebody on the defensive, but helps them build more knowledge, because we each have a piece of that puzzle that we can share. And so, yeah, going back to Dr. Koo, building your relationships is key.
Now, with that being said, I do want to point out a few things I think many of us and many institutions are experiencing is that nurses they have their plates full. I mean, and it's hard. I mean, they have, and I'm just going to speak from just what I hear from Billings Clinic and the expectations of some of what our nurses here have to, that they're required to do for the most part. And they all it ranges quite vastly. They're not just, just routine nursing care. Now we're they're counselors, they're making sure people don't fall. There are all these different things. And so as you're kind of, although these are great, I think nurses can be very important part of a successful antibiotic stewardship program. But you also have to be mindful as you're designing these interventions, you have to see what they have on their plates. Otherwise, you're not going to get the result that you hope to get. So, and that's and I'm just going to say that is one of our biggest challenges, that our nurses are being asked to do so much.
Right.
And then now, if we're going to throw when you go there and you throw this on them, they're probably going to give you the look. So you do have to kind of work on that relationship and then see how this is going to work into their workflow, because in the end, that's, and this is not just for nurses, but this also, when you're designing interventions, it's going to be physicians as well. How this is going to affect their workflow. And that's on top of all the issues that Terry brought up about coming across as being the expert, some expertise. Do they have that authority to sound like, hey, Dr. Jones, I have a patient that, you have him on, who's being treated for pneumonia, he's on ceftriaxone and azithromycin. Can we switch him to oral? I mean, and there's that intimidation factor until they're all sorted with what all the million things that they're thinking about. That's going to be one of the last things they're going to consider. So there are things, as you're building this, I'm really encouraging all of you to try to do something with the nurses, but just be mindful as you integrate them, your interventions, be mindful of all the things else that they're doing, especially with diagnostic stewardship, because that diagnostic stewardship is one of those things that it sounds great. Implementation is not as easy as it sounds, because of a lot of because many of the interventions directly affects workflow, right? You're telling the nurse, if you get an order for example, C. diff, you got to get them stopped. You want to make sure, okay, am I ordering is this the appropriate patient? Now you're making that nurse into that checkpoint. And that is a new barrier in their workflow if they're seeing 20, 25 patients. So these are things that kind of throw as I'm putting these as you're considering these interventions.
Yeah, approach is important, because your approach can drive building that relationship, or your approach can alienate that relationship from the get-go. And I think part of that approach, as the IP would be up on the unit mentoring that frontline staff, helping them see why getting that patient from an IV to a PO is going to help their workflow. It's much easier to give a pill than to give an IV antibiotic. If I can get them to oral antibiotics and they have no other need for that IV, I can get that IV out, which decreases my workload, because now I don't have an IV that I'm monitoring, and it reduces the risk of that patient developing an infection, whether it's a central line or a peripheral line. So I agree that we have to be mindful. And I think that was a key piece learning when we had IPs join our team that were not nurses or didn't have a medical background, and they didn't understand why, if you go up to a unit at 7 in the morning and you want to provide education and ask a ton of questions, you're going to alienate both your night shift and your day shift. So approach and making sure that whoever's doing that work understands how to build a relationship and build that trust, so that when I go on the unit, the staff would stop and ask, can I ask you a question? Can we talk about? Or they felt comfortable picking up the phone and calling me to say, help me understand what I need to do. So yeah, approach is key, and you want to build a positive working relationship.
If you have a moment, Jenna, do I have authority to share something on my screen?
Yeah, you should.
I do. You're all going to be one of the first to actually get to see this. But so this is actually a schematic I put together regarding the relationship between antibiotic stewardship and diagnostic stewardship. And Terry kind of described the diagnostic stewardship as a separate entity, but but in reality, it's really done both at the same time. And a
Right.
lot of things that we've done there are a lot of things we have done in the past as diagnostic stewardship. We just never thought of that term until in the last 5 to 10 years. But there are certainly differences, and this is why I wanted to kind of bring this out, and hopefully you can kind of take this the recording and this graph this figure and kind of see how this plays into your stewardship program. So most of diagnostic stewardship have been really focused on what we call the upstream effect. That's upstream from the ordering of or prescribing of medications. Because the theory is that if we can influence the clinician into making the proper right diagnosis, then they wouldn't be ordering the antibiotics inappropriately. That's the theory. And so everything that Terry talked about, again, I'm using the C. diff example, making sure that you're testing unformed stools. You make sure that there are at least 3 unformed stools in the past 24 hours. Make sure there's no stool softeners or laxatives. Those are things that we try to implement and who have been implemented in the past, and they're essentially our diagnostic stewardship. You're trying to tell and nudge the clinician, hey, before you order that test, make sure that this is the right patient. Now, I think nurses are very integral in this because they can play a cross-check role in the sense that they can do this if you give them a checklist to do this. Mind you, that I also want to kind of caveat, nurses are also guilty of testing more because they are at least I've seen from my peer that so-and-so has a diarrhea, so maybe I should just go ahead and order a C. diff test on behalf of my doctor. Or probably even more concern is the smelly urine. Hey, Mrs. Smith has this smelly urine, I'll just go ahead and order. So there is that component as well. So kind of thinking that as you're kind of integrating this diagnostic stewardship, make sure your nurses are also well educated from that perspective. But my point being here is that a lot of there's that diagnostic stewardship is really upstream, but it does affect, as you can see on the graph, the spectrum of the patient care process, where a lot of it, I think there are things you can do from a testing perspective, and that's not just ordering a test, but also as well as collection and reporting that can influence prescribing habits. And that's so my point being is, don't think this as 2 separate entities, but they're really complementary to each other. But also that you do, it's not a scenario where you just pick 1 or 2 interventions and that will solve your problem, but that this many times to reach your goals, you probably will need a bit of some intervention from both realms, domains, to kind of to help to get to increase the chances of where you're trying to go, whether to reduce inappropriate treatment of asymptomatic bacteriuria, to C. difficile testing and such. So anyway, I just want to kind of add that just slide up, but they complement each other as you're and that and you should kind of really try to use a little bit of both in your at your programs.
Excellent. Thanks, Dr. Koo. Comments, questions? What else out there?
Everyone's quiet.
Okay. Again, I want to be respectful of everyone's time. We really enjoy your joining the webinar. So with this theme kind of going forward, then what we'd like to be able to do for next month is collect some of those issues, those problems that you're seeing that are plaguing you, as that you consider that big log that you got to get over to get things going or to gain some momentum. Is it selling your program to administration? Is it getting administrative buy-in? Is it the fact that you have all your nurses or pharmacists or physicians they're leaving, and staffing issues and resources, human resource issues? Is it, how do you communicate with your providers? Is it a major diagnostic stewardship issue? Is it something else? Is it that relationship building? How do we start that? So we'll put these together, maybe like in a packet of potentials, or if you have something different, please put that down. And we're going to collect those and maybe next time break out into the groups again and see if we can break them down and get some answers and get some discussion and participation going. Does that sound okay? Dr. Koo, Jenner, got anything else to add? Okay. We are done. You guys have a great rest of your Wednesday and a great rest of the week. Stay
Thank you.
warm.
Thank you
Thank
for
you,
the
Terry.
opportunity. It's good to
Thank
see
you
you.
very much, Terry.
You're welcome. Bye-bye.
Thank you.